According to the Kaiser Family Foundation, over 100 million people in America are in debt to a hospital. It's a number so vast it becomes abstract, a national crisis that feels like background noise, a statistic you might hear on the evening news and forget by the next commercial break. Until it happens to you. For David Carter, a 42-year-old high school history teacher, the noise became a scream. It arrived on a Tuesday in a single, deceptively thin envelope from the hospital that had saved his life just 3 weeks earlier. Inside, a list of services and alphanumeric codes that made no sense, and at the bottom, a number that felt like a life sentence. A routine appendectomy, an operation performed thousands of times a day across the country, had generated a bill for $117,000. He stared at a charge for a single tablet of acetaminophen, Tylenol, priced at $105. What David didn't know, what almost none of us are meant to know, is that these numbers weren't a mistake. They weren't an oversight or a clerical error. They were pulled directly from a document hidden from plain sight, an internal ledger with no connection to the actual cost of care or to any recognizable reality. This is the story of that document, the source of an anxiety felt by millions. We call it the Phantom Price List. Unraveling this list reveals the true architecture of American medicine. A system where the price of care is deliberately obscured, negotiated in secret, and weaponized against the most vulnerable. At its core, the logic is brutally simple. It's not healthcare, it's a balance sheet. David's bill wasn't an outlier. It was the intended outcome of a system working exactly as designed. But the most terrifying part wasn't the impossible total at the bottom of the page. It was the realization that this phantom number could have real-world consequences, and the key to understanding how was hidden in the absurd price of that single, ordinary pill. David's story isn't an anomaly, it's a template. In 2020, a ProPublica investigation revealed that Yale New Haven Hospital, a prestigious tax-exempt, nonprofit institution with an endowment in the billions, had sued over 3,000 of its own patients for unpaid medical bills in a single year. These weren't millionaires dodging payments. They were cafeteria workers, retail clerks, and retirees, hounded with lawsuits and wage garnishments by the very institution they trusted to save them. When you zoom out from a single hospital to the entire country, the scale of this becomes staggering. The 100 million Americans carrying medical debt now collectively owe over $220 billion. To put that number into perspective, it's more than the entire gross domestic product of Greece. This isn't a fringe issue. It's a parallel economy built on personal catastrophe, a leading cause of personal bankruptcy in the United States. So, let's connect the dots. You have a celebrated nonprofit hospital behaving like a loan shark. You have nearly a third of the adult population saddled with healthcare debt. And you have a national total that rivals the economic output of entire countries. When you realize the pattern, you start to see the machine. The operator of this machine isn't some shadowy figure in a boardroom. It's the American hospital system itself, an anti-hero that has quietly transformed its mission. Its primary function is no longer just patient health, but institutional financial survival pursued with the cold, impersonal logic of a predator. The fallout from this quiet transformation is a country drowning in debt for the crime of getting sick. It's a house of cards where the slightest breeze, a broken arm, a sudden diagnosis, can bring everything crashing down. But this raises two fundamental and far more disturbing questions. First, how did institutions founded on the principle of charity become some of the nation's most aggressive debt collectors? And even more critically, what gives them the right to sue for these astronomical sums in the first place? Where do the phantom numbers on the bill actually come from? The two questions, how and why, converge on a single maddening paradox. Ask a hospital spokesperson about a $100 Tylenol, and you'll get a practiced, reasonable-sounding answer. They'll tell you these list prices are not meant for patients. They are an artifact, a kind of sticker price that only exists as a starting point for complex, high-stakes negotiations with giant insurance conglomerates. They will look you in the eye and insist, with perfect sincerity, almost nobody actually pays that price. And that single word, almost, is where the entire system's cynical genius is hiding. Because it raises the one nuclear question that dismantles their entire defense. If the price is just a fictional negotiating tool, a piece of strategic theater for corporations, then on what legal or moral grounds does it become terrifyingly real for the uninsured? For the underinsured? For people like David? How can a number be both imaginary for an insurance company and a legally enforceable debt for an individual human being. This is the central deception. The system presents itself as a free market, but it violates every principle of one. There is no transparency, no ability to comparison shop, and an extreme power imbalance between buyer and seller. So, what is the fundamental difference between the cost of a procedure and the price on the bill? The answer requires us to pull back the curtain on the hospital's inner sanctum to a place where medicine and predatory finance become indistinguishable. At its core, it's a system where price has no relationship to value. It's a house of cards built on a single hidden document. That gap between cost and price isn't a gray area. It's a chasm. The architecture of this system is built on one core principle. What a service costs the hospital and what you are charged for it exist in entirely different universes. This isn't speculation. It's a statistical fact, documented in plain sight by researchers who have managed to peek behind the curtain. A landmark 2020 study by the Rand Corporation found that, on average, U.S. hospitals charge patients with private insurance 247% of what they accept from Medicare for the exact same service. Let that sink in. For the same procedure, with the same doctor in the same room, using the same equipment, the price is algorithmically multiplied by nearly 2.5 times, simply based on who is paying the bill. The numbers only get more surreal from there. A 2015 analysis in the journal Health Affairs examined the cost-to-charge ratio at top-grossing hospitals. In plain English, that's the gap between what a service actually costs and the fantasy number they put on the bill. They found the average markup was 7 times their actual cost. The fallout from this is a $100 Tylenol, a $1,000 bag of Salin, a $500 charge for a nurse to hand you a pill. These aren't clerical errors. They are the direct output of the phantom price list. When you realize that the Commonwealth Fund reports the U.S. spends nearly double per person on healthcare than other wealthy nations, yet we have demonstrably worse health outcomes on nearly every major metric, the picture sharpens. You're paying premium prices for an inferior product. The system isn't broken. It's ruthlessly efficient at its true purpose, which is extracting the maximum possible revenue from every single patient interaction. This leaves us staring at the wreckage. A system of deliberate, aggressive, and mathematically absurd price inflation that has no parallel in any other developed economy. This was not an accident. It was designed. Which forces the most unsettling question of all. How did we get here? What kind of history could forge a system like this? The modern American hospital was not born a predator. Its origins were, in fact, noble. For much of our history, hospitals were charitable last resorts run by religious orders and communities, places where the poor went to die with a measure of dignity. They were funded by donations, not transactions. Their balance sheets were measured in lives comforted, not revenue captured. This was the seed, an institution built on the principle of sanctuary. The ascension began after World War II. A convergence of forces transformed these humble charities into the medical empires we know today. The 1946 Hill-Burton Act flooded the country with federal funds, building thousands of new, modern hospitals. Simultaneously, a quirk of wartime tax policy led to the rise of employer-sponsored health insurance, creating a vast new pool of paying customers with deep pockets. Medical science exploded with new cures, new technologies, new miracles. The hospital was no longer a place to die. It was a place to be saved. It became the gleaming, trusted centerpiece of every American city, a symbol of progress and power. They were, for a time, the unambiguous heroes of the story. Then came the fall. The catalyst arrived in the 1980s, a 1-2 punch that sent the entire system into a state of financial shock. First, the federal government, buckling under the rapidly rising cost of Medicare, fundamentally changed the rules. Instead of simply reimbursing hospitals for whatever they spent, they introduced a system of fixed payments based on diagnosis. Suddenly, for their single biggest customer, the government, hospitals were given a set price for every procedure, and not a penny more. The open spigot of cash was slammed shut. Almost immediately, powerful private insurance companies saw their opening. They used their massive leverage to demand similar, deep discounts, refusing to pay the hospital's listed prices. The hospital was now caught in a vise, crushed between the fixed, non-negotiable prices from its biggest buyers and the ever-rising costs of technology, labor, and medicine. For the first time in its modern history, the American hospital was facing a genuine existential crisis. The celebrated heroes were bleeding out. Uwe Reinhardt, the legendary healthcare economist, perfectly described the mentality that followed. It is as if the hospital industry is saying, we will get our money one way or another. If you pay us less, we will charge someone else more. This was the rebirth. Cornered and desperate, the system engineered a new architecture for survival. It couldn't control what the government or big insurers paid. So, it focused on the one thing it could control: its own internal, private, and completely unregulated price list. The logic was brutally simple. If you have to give 70% discounts to your biggest customers, you don't lower your costs. You just raise the starting price by 700%. You create a fantasy price list, a ledger of numbers with no basis in reality, so that even after the massive negotiated discounts, the final payment is still enough to guarantee a profit. The fallout from this decision created the system we have today. A system where the price is imaginary, except for the few who can least afford it. This secret ledger, this book of phantom numbers born from a moment of crisis, would become the foundational document for the entire industry. It's the source code for David's $100 Tylenol and for 100 million Americans in debt. It has a name. And now, we will finally reveal it. The document born from that moment of crisis, the one we've called the Phantom Price List, has a real name. It's a term that was almost completely unknown to the public until 2013, when journalist Stephen Brill published a landmark investigation in Time magazine titled Bitter Pill. He gave it a name that sounds almost mythological, like something out of a medieval accounting ledger. It's called the Chargemaster. The Chargemaster is the hospital's secret Bible and its primary weapon. It is a master list, sometimes containing tens of thousands of individual items of every single service, supply, and procedure a hospital could possibly provide. From a single aspirin to a complex open-heart surgery, everything has a line item. And next to each line item is a price untethered from reality, bearing no relation to the hospital's actual cost. This is the source code of the entire billing system. At its core, the logic is a masterclass in strategic inflation. You see, the hospital knows that its biggest customers, the giant insurance conglomerates and the federal government, will never pay the list price. They will demand and receive massive discounts. So, how do you ensure profitability when your main clients get 60 or 70% off? You don't try to negotiate a better discount. You simply multiply the starting price by 10. The Chargemaster is that multiplication. This isn't an exaggeration. Let's unravel the math. We know from the Rand Corporation's research that privately insured patients are charged, on average, 2.5 times what Medicare pays. But that's the final price after the so-called discounts. The starting point is far more absurd. A 2015 study in Health Affairs found that the 20 top grossing hospitals in the US had an average markup of 7 times their actual costs. For some, it was over 10 times. That's a 1,000% markup. This is how a bag of saline, which costs the hospital about $1, can appear on a bill for $200. It's how David's Tylenol gets a price tag of $105. The hospital's defense is that the Chargemaster is just a formality, an internal tool for negotiation. But this is the system's most profound deception. Because the moment a patient is uninsured, underinsured, or receives care that falls outside their network, that formality instantly transforms into a legally binding debt. The phantom becomes real. The fictional number is used as the basis for lawsuits, for wage garnishments, for property liens. It is the financial equivalent of using a stage prop from a play as a weapon in a real-life assault. In 2021, the government tried to address this with the Hospital Price Transparency Rule, which required hospitals to post their Chargemasters online. But a 2022 report from the Government Accountability Office found that compliance has been low, and even when hospitals do comply, the data is often posted in complex, unusable formats, impossible for a normal person to decipher. The secrets remain protected. This isn't to say every hospital administrator is a cartoon villain, twisting a mustache while cranking up prices. It is to say that they are operating within an architecture of incentives that makes this behavior not just possible, but rational. They are serving the financial health of their institution, because decades of policy have forced them into a corner where that is their primary mission. The fallout is a system where the sick are not patients to be healed, but revenue streams to be maximized. When the very tool designed to negotiate with corporate giants is turned against a high school teacher fighting for his life, you have to admit the mission has changed. It's not healthcare. It's a balance sheet. So we found the source. We've named the weapon. We understand the cold logic behind the machine. The loops are closed. But this only opens the final, most important door. We now see the architecture of the system in its entirety. A house of cards built on a foundation of phantom numbers. What happens when a human being, a real person with a family and a future, is crushed beneath its weight? What happened to David Carter? So what happened to David Carter? What happens when a human being is caught in the gears of this machine? His story didn't end with a foreclosure or a bankruptcy filing. It ended with a whimper. After 6 months of agonizing phone calls, of navigating a bureaucratic labyrinth designed to exhaust him, of enlisting the help of a patient advocate, his $117,000 bill was reevaluated. The hospital, in a gesture of what it framed as profound generosity, reduced the total to $22,000, a sum he could finance, a debt that would follow him for the next decade. He was expected to feel grateful. The fallout for David wasn't just financial. It was the psychological toll. The gnawing realization that the institution he trusted in his most vulnerable moment saw him not as a patient, but as a rounding error on a spreadsheet. His life was saved in the operating room, only to be held hostage in the billing department. And this is where the true, uncomfortable nature of this system comes into focus. At its core, the architecture we've unraveled, the phantom price list, the Chargemaster, is, from a purely financial perspective, a brilliant, if brutal, adaptation. It's the logical response of an organism backed into a corner by decades of policy and market pressure. It is a masterclass in survival. This is the cognitive dissonance at the heart of the American hospital. It is a house of cards built on a paradox, a system that performs daily miracles of science and compassion, funded by a mechanism of predatory finance. The doctors and nurses fighting to save you are heroes, but they work inside a fortress whose walls are built from phantom numbers and whose survival depends on someone, eventually, paying the sticker price. We now understand the mechanics. A secret price list inflated by 1,000%, used as a fictional starting point for negotiations with corporate giants. A legal loophole that allows this fantasy number to become a terrifyingly real weapon against the uninsured and the out-of-network. And a nonprofit status that provides a tax-exempt shield for what is often the most aggressive debt collection in town. The only way to challenge an architecture of deliberate confusion is with deliberate clarity. It begins by refusing to accept the final number as fate. It begins by demanding the itemized bill, by questioning the $100 Tylenol, by searching for the hospital's publicly posted, but often deeply hidden, Chargemaster files. Transparency is the first crack in the foundation of this house of cards, because a system built on secrets cannot survive the light. Ultimately, we are left with the wreckage, 100 million Americans in debt, a nation that spends more than any other for worse outcomes, and a teacher who will spend the next 10 years paying for an emergency surgery that should have been a footnote in his life, not a defining chapter. Which brings us back to the fundamental question. The one that haunts every absurd bill, every collection call, every family forced to choose between their health and their home. If a system designed to save lives simultaneously destroys them financially, has it failed in its primary mission, or is it succeeding at a different one we were never meant to understand? The crippling hospital bills are just one symptom of a much larger disease. But what if the cure itself was the weapon? Our next investigation exposes a company that bought life-saving drugs just to make them unaffordable. To see the full story, make sure you subscribe and follow our content.